Good afternoon, everyone. Thank you for joining us today. My name is Renee, and I welcome you to the library this afternoon. I also would like to welcome our viewers who are watching our program via live stream. If you would please, note the feedback forms on the back table and take a moment on your way out to give us some, share your thoughts on our programming, give us some feedback that helps us plan our future events. Today's talk is part of a medical topic series throughout 2025 that the library is proud to offer with UAMS Family Medicine and the College of Medicine. This series features doctors, social workers, and nurses presenting valuable information about a variety of health issues. We have a flyer on the back table that lists all the programs, and that's what that looks like. Be sure to grab one on the way out. Our next program on September 12th will be about the dangers of and how to prevent slips, trips, and falls. Our topic today is diabetes, types, symptoms, risk factors, and complications from this condition. It's my pleasure to introduce our speaker, Dr. Natalie Rodriguez. Dr. Rodriguez is an assistant professor with the UAMS Northwest Regional Campus in Fayetteville and sees patients at the UAMS Family Medicine Center in Springdale. I'm going to turn it over to Dr. Rodriguez. Thank you for being here.
All right. I think that it's so cool that the library has started this series and is really putting some concern into the public health of Fayetteville. And so I love that we have been invited to come and participate in this. So thank y'all. Okay, so let's see. I know how to operate. There we go. So first, just a little bit about myself. I am originally from Texas. I grew up in a very small town outside of Houston. Just a real small town in East Texas, but I always tell people Houston because otherwise you won't know where it's at. For my education, I went to the University of Texas in Austin, so I am a Longhorn. There's not a lot of love for us Longhorns up here. I get it, but I like to brag on them every chance I get. From the University of Texas, I went to Ross School of Medicine for my medical degree. And then I came to Fayetteville for my residency. I participated and did my family medicine residency training here in Fayetteville with UAMS, who is now my employer. So I liked it so much up here. I liked my colleagues. I believed in the program that I decided to stay on and become a fellow Arkansan with y'all. And that's where I'm currently employed. Some hobbies, I love being outdoors, which is a big pull, obviously, for staying in Northwest Arkansas. The weather's great up here. I know y'all think it's humid, but come down to Houston and you will see it is so not as humid as it could be. I have a Great Dane, which I have listed right here. He's my second Dane. I love my dogs. And then I'm a member of Calvary Church in Lowell, that I spend a lot of my free time socializing with them. But y'all came to learn about diabetes. So before we get started, a quick disclosure. I have no financial disclosures to give. I have no conflicts of interest. We will be talking about some medications today. There is no financial gain for any medication, any form of treatment that I am discussing today. I am only bringing them up because I believe that they make a difference in diabetes and they can make a difference in your quality of life and in your health. So our learning objectives for today, before we can talk about diabetes and understand what's going on, we have to know what the role of glucose is in our body and the role of insulin. So we're going to start there. Then we are going to talk about what the definition of diabetes actually is and how do we diagnose it. We're going to move on to some signs and symptoms that you'll see, but we're going to spend a very large portion talking about the treatment of diabetes, and then not just treating it, but focusing on how do we prevent all of the long-term complications that you can be affected by if you are someone who struggles with diabetes. Okay, so glucose, AKA sugar. From the time we're little, what are we taught? Sugar's bad. When you're a kid, sugar makes you hyper, it'll rot your teeth out. When you become a teenager, it's if you eat sugar, you're going to have a breakout, you're going to gain weight. When you're older, it's, oh, if you eat sugar, you're going to develop diabetes, you're going to have hypertension. We're just constantly, it's negative, negative, negative. But the truth is our body's primary fuel source is glucose. We have got to have sugar. We've got to have glucose. Everything that our body does, every time you breathe and that diaphragm contracts and you breathe without having to think about it, it's relying on glucose to be able to do that. So it's our primary source of energy, so it's not all bad. We rely on it. But what happens is every time we eat, that food enters our digestive system, then our body does what it's supposed to do. It breaks it down into different molecules. It breaks it down into the glucose. And then that glucose is in our blood. But in order for our body to be able to use it, it has to enter a cell. So it's kind of like when you have gas in a gas can and you have a car that's ran out of gas on the side of the road. If you can't get that gas out of that gas can and into that car, it's not going to do you any good. So in order for our bodies to use this glucose, it's got to come from our bloodstream and get into our cells. And that's where the pancreas comes into play and insulin. So how many here, maybe you're on insulin or you know someone who's been on insulin as part of treatment for your diabetes? So insulin is that key that opens up that door and allows the glucose to leave your bloodstream and get into your cells. So some cars now, on that gas lid to your car, it has a lock. So insulin would be the key that unlocks that so I can get my gas from the gas can into the car. So now that we know about glucose and insulin, this is just a little schematic. Again, insulin representing the key that's going to unlock the lock and allow your blood sugar to get into your cells so it can do what your body needs it to do. So now let's talk about what the definition of diabetes actually is. So it's a metabolic condition that is characterized when you have too much glucose in your blood, because what did we say? You can't keep it in your blood. You've got to get into your cells. And there are some different ways that that can malfunction, and that's what leads to increased sugar in your blood, which is what diabetes is. One reason could be is that you don't make enough insulin. Okay, so type 1 diabetics. This is a type 1 diabetic. They don't make any insulin. They have no keys, no way of their body being able to say, all of this good glucose that's in my blood, let me bring it into my cells. But then you can also have a type of diabetes where you have insulin in your blood, but those cells just aren't listening to it. So this is kind of like, I was thinking about it last night with my dog Kylo, because in and out, in and out. He loves to be outside until you shut the door. Once he knows the door is shut, he wants to come back inside. So we play this game where he goes outside, I shut the door, and he comes back. He barks. I go and I open the door. He goes back out. 10 minutes later, he barks. Go and open the door. Eventually, what happens? When he barks, I say, no, you can stay outside. Your body can do the same thing. When you eat something that causes your glucose to rise, your body does what it's supposed to do, and it releases insulin, and those cells, they say, oh, there's insulin, let me open the door so my glucose can come in. But then if 30 minutes later you do the same thing, well, maybe 30 minutes later, they open the door. But eventually your body gets to the point where it says, I'm tired of opening this door every 30 minutes. And so it becomes less responsive to that insulin. So that's what's happening in type 2 diabetes. Just like if you're knocking on that door, it'll open. It'll open. But eventually, if you start getting ignored, what do? You have to knock a little harder, knock a little longer. And so that's how your body begins to try and overcome. Your pancreas says, well, it didn't listen to the amount of insulin that I produced the first time, so let me produce a little bit more. Let me make a little bit louder of a signal to try and get my body to respond, to open up this door so I can use that glucose. And so when it becomes less responsive and more resistant to the insulin that's being produced, that is what we call type 2 diabetes. So type 1 is an autoimmune condition, meaning your body is attacking itself. Your body sees its own pancreas as something that's a danger, and it makes antibodies and it attacks it. And eventually your pancreas gets so damaged that it's not able to make any insulin. And so no insulin, no keep. There is nothing you can do to prevent this. This is purely a genetic condition. It's like if you have a hypothyroidism or if you have rheumatoid arthritis. These are all autoimmune conditions where it's not because you have lived maybe an unhealthy lifestyle or you made some wrong eating choices or you don't exercise enough. This is truly genetics. And that's why we see this develop in childhood most of the time. If you're early 20s and you're just now developing type 1 diabetes, you're really late to the game. This usually happens much, much younger in childhood. There are 2 million Americans each year who are being, not diagnosed, there are 2 million Americans each year who are being treated for type 1 diabetes. So not as common as type 2, which this is what we refer to, that insulin resistance that I was talking about earlier. So this is not purely genetics. We do know that if you have a family history, that increases your chances, but this is the type of diabetes that can be prevented. So with lifestyle changes, with healthy eating habits, with exercise, but 38.4 million Americans each year are living with type 2 diabetes. So it can be prevented, but obviously it's still very, very common. And this is usually onset much later in life because it takes a while for your cells to get tired of that repeated signal. You know, your pancreas is able to overcome and knock a little louder and knock a little longer for a certain amount of time before your body finally starts saying, okay, enough is enough. So that's why we see this onset much later in life. So just some statistics about diabetes. And these statistics came from the American Diabetic Association. So with a lot, have you all ever heard of the American Heart Association or the Headache Society? These are groups of people that all of their money, all of their energy, all of their finances, all of their resources goes into one thing. They care about diabetes. And so they're the ones that we look to for when new treatments are coming out. They're the ones leading the way in the research. And so these statistics are from the American Diabetic Association. And as of 2023, diabetes is the 8th leading cause of death in the United States. As already mentioned, 38.4 million Americans are diagnosed and are living with type 2 diabetes, but 1.2 million every year is added on to that number, okay? 97, almost 100 million people are pre-diabetic. So there is something that we can check in your blood that lets us know you're not fully diabetic, but you're about to be. If we don't make some changes, your body is already your pancreas is already having to talk a little bit louder. We're beginning to see some things that lets us know that that's where we're headed if we don't make some lifestyle adjustments. And there are almost 100 million Americans outside of that 38.4 who are in that pre-diabetic range. Certain ethnicities increases your chances of developing diabetes. Native Americans is the highest percentage, followed by non-Hispanic Black Americans, then Hispanic Americans, Asian American, and then your non-Hispanic white adults. 44% of our dialysis patients are on dialysis due to diabetes. Does anyone here know anyone on dialysis? Let me tell you, dialysis is a game changer. It is 3 days a week, sitting for 4 to 6 hours in a chair every week. You want to go on vacation? You can't go unless you find a dialysis center in that town that you're going to that's going to be able to continue your treatment. We have people that we admit, I was at the hospital before coming here. They miss one session and now they can't breathe, or their toxins have built up in their body and they can't eat because they're so nauseous. That's 3 days a week. Some people drive an hour to get to their dialysis center because all the ones here in Fayetteville, there's no room at the end. The spots are full. Dialysis is not something that's easy to deal with. Almost half of people that are on dialysis due to diabetes. 80% of the non-traumatic amputations are due to diabetes. We have a lot of diabetic patients who unfortunately have to have toes amputated or feet amputated. Diabetes is serious. You may know a lot of people who's on diabetes and it's, oh, they just take a pill for it. It may not seem like a big deal, but it really is. And that's what hopefully we can walk away from today, realizing that it's not something to play around with. And if there's anything that I can do to try and prevent myself from developing diabetes or try to prevent my diabetes from worsening, then I want to take it seriously and I want to do it. Okay, so what are the risk factors? We've already talked about some of them. And a lot of these won't be too surprising to anyone here. Being overweight increases your chance of diabetes because remember, if I'm eating more, my pancreas is having to produce more insulin, and then eventually my body gets a little resistant to it. So being overweight is a risk factor. Being inactive, so if you are not exercising at least 3 times a week, then your chances of developing diabetes goes up. Having a family history. So again, this does play into type 2 diabetes. A lot of it is because we know that we are products of our raising. So if we are raised with a certain lifestyle and we're maybe raised in a family that doesn't teach us to prioritize physical exercise and healthy eating choices, then we're probably not going to do that ourselves as an adult. And so those are some of the things. If my parents were diabetics, then I have a greater chance just because of the learned habits. But then also, there's also genetic factors that are part of it. Your pancreas or your cells may be more easily become resistant if you've got some genetic predisposition to that. The older you are, the greater the chance of developing it. If you have fatty liver disease, then your chances of developing diabetes goes up. If you've ever had gestational diabetes, so everybody that is going to have a baby, that is something we do. We check for gestational diabetes. And then most of the women who have gestational diabetes, we treat their diabetes. Once they deliver, it goes away. But even when it goes away, that tells us that later on in life, you're going to have a greater chance of developing diabetes. And then the certain ethnicities that we have already discussed. So what are some signs and symptoms? Okay? Because a lot of people don't know that they have diabetes, right? You're not diagnosed until you're diagnosed. So people don't come to the doctor and say, I think my sugar's high. I feel like my sugar's high. No, they come in complaining of, I may have a UTI because I've got to go to the bathroom all the time. I mean, I am just constantly in the bathroom. What is going on? Maybe they have frequent UTIs, okay? Or they're really exhausted. What did we say glucose was? It's our fuel source. So if it's hanging out in our blood and it's not getting into our cells like it's supposed to, well, these people come in and I'm tired all the time. You can have unintentional weight loss. Your body is trying to fix itself, okay? It's trying to say something's got to change. So a lot of people who have had diabetes go untreated for a long period of time eventually come in and they're experiencing unintentional weight loss. You can be intensely hungry or thirsty. You can have numbing and tingling in your extremities. And then you can notice, I cut myself weeks ago and it's still not well. What's happening? It doesn't look infected, it's just not getting better. These are all signs and symptoms of diabetes, and we're going to talk about why. So if you have some of those symptoms, you may be thinking, well, how do I find out? How do I know for sure? Do I have diabetes? Do I not have diabetes? You can go to your doctor. There's lots of different ways to diagnose diabetes. The most common way is through a blood test, something called an A1C, which the cool thing about an A1C is that it's going to give your average blood sugar for the last 3 months. So how many, when you are going to the doctor, you eat healthy that day? You got a doctor's appointment and you drive past McDonald's because, oh, I'm going to the doctor and he may ask me what I ate this morning. So you eat healthy. Some people, they get stressed and they say, I got to go to the doctor. Let me stress eat. And they stop by Krispy Kreme on the way and they get a donut. So if I check your sugar and you've just had a donut, it's going to be really high. But maybe you eat healthy the rest of the week. Or maybe you're the person who eats donuts every morning or McDonald's every morning, except for the day that you go to the doctor. If I were to check it then, it may not be as high. So it's not as good of an indicator as this A1C, which tells us your average glucose for the last 3 months. Doesn't matter if you had water with a side of celery for breakfast or if you had McDonald's. It's going to give us one number, okay? So if your A1C is greater than 6.5, you have diabetes. You can do a random glucose test. So how many have ever checked their sugar at home? Maybe you have a grandparent or an aunt or uncle that they're checking their sugar and you say, hey, let me check mine too, see what my sugar is. So if your sugar is ever above 200 and you're experiencing any of those symptoms that we just talked about, that's enough to say you have diabetes. If you check your sugar twice and it's above 200, you have diabetes. If you wake up in the morning and before you have eaten anything, if your sugar is greater than just 126, you can say you have diabetes, all right? As a doctor, we like to screen for diabetes. You may not have any symptoms. And if you are over the age of 35 and you are overweight, and let me tell you, it doesn't take much to be classified as overweight. It really doesn't. So if you're over the age of 35 and you're overweight, we're going to screen you for diabetes because the sooner we can catch it and the sooner we can get that glucose under control, then all of those bad things that happen to you when your sugar is just left to sit at this high level, we're going to try and prevent it. So this is why your doctor may talk to you about screening. So this will over here, this is where we're about to get to why you actually care. Why do I care if I have diabetes? Because of this thing right here. So it's a little blurry, I realize that. You got 3 portions right here that is representing an eyeball. Sugar damages your eyesight. High glucose damages your eyesight for multiple reasons. It's the leading cause of preventable blindness in the United States. Okay, there's a ton of people who go blind every year because their diabetes is uncontrolled. The kidney, what did I say? 44% of people on dialysis is on dialysis because of diabetes. So we know that diabetes damages your kidneys. We know that diabetes can cause you to go blind. You have strokes, heart attacks, peripheral artery disease. We know that diabetes, when left uncontrolled, damages your arteries, damages your veins, leads to things like strokes and heart attacks. It's not just that we're wanting to keep your sugar low. We're wanting to prevent you from having a stroke so that you don't lose control of the right side of your body. We're wanting to keep your glucose at a manageable level because we don't want you to have an amputation of your toe or an amputation of your foot. And you may love hiking, but once you get your amputation, that's going to be really hard to do. Or you may love bowling. I had a patient who had a stroke who he just wanted to be able to go fishing again. He right-handed, he loved to fish, uncontrolled diabetic, had a stroke. He lost his enjoyment of fishing. So this is what we're trying to prevent. And so we're going to talk about the treatment, and not just the treatment, but how we try to prevent each of those things from happening. So when it comes to treatment, there's lots of options. There's insulin. There are so many oral pills. Like when training the residents, it takes a couple of years for the residents to really get down all of the medications. There's a lot of different options out there for you. And then there's lifestyle changes. With insulin, I've never had a patient come to me and say, sign me up for shots. Never. People don't like shots. I get it. But if you're wanting to control your glucose as quickly as you can and as well as you can, insulin is a great way to do it. If your A1C gets above 10, so remember we said an A1C greater than 6.5 is officially the diagnosis of diabetes. If your A1C gets above 10, then we're going to recommend you go ahead and get started on insulin because we know that means your sugar is really high and your risk of having all of the organs damaged that we just discussed is getting greater and greater by the day. Excuse me, just a second. Okay. So, biggest part of diabetes management is that we're not just here to play defense. We've got to be offensive, okay? in treating our diabetes. I don't want to just keep my glucose controlled, but I want to make sure I'm doing everything I can to keep my kidneys as healthy as I can, to keep my arteries as healthy as I can. So how do we do that? With diabetic nephropathy, first of all, with any of these organs, number one thing is keeping your glucose down, keeping that sugar down with the different either insulin injections or diabetic pills. But specifically with kidneys, so 20% of the diabetics, so we said it was 38.4 million adults are living with type 2 diabetes. 20% of 38.4 million, that's a lot of patients. I can't do that math in my head right now, but that's a lot of patients who are struggling with already chronic kidney disease because of their diabetes. And 44% are going to end up on dialysis, okay? So how do we prevent that from happening? Yes, I keep my glucose controlled, but what else? Every year your doctor is getting a urine test. So it's not just to be annoying. You know, sometimes you go to the doctor and they ask for a urine sample and you're like, I just went. Can I come back another day? And then you never come back. The reason we want that urine sample is because we're trying to make sure, are your kidneys working as well as they need to work? Because if not, then I don't want to just give you a medication to keep your sugar controlled. I want to give you a medication to help protect your kidneys. And sometimes those medications are actually blood pressure medications. And so some people will say, my blood pressure is great. Why are you starting me on a medicine for my blood pressure when I'm here to talk to you about my diabetes? It's because those medications we know will protect your kidneys and will decrease your chances of ending up on dialysis. Making sure your blood pressure is really controlled, okay? Sometimes we call blood pressure, hypertension, a silent killer because you feel fine. When you have high blood pressure, unless it gets like really, really high, chances are you won't feel anything. You probably won't have headaches, you won't have chest pain, but if your blood pressure is sitting at 150s, 140s, that's going to increase your chances of ending up on dialysis, so we want to make sure we're really controlling that, even if you feel okay. And then also working with a dietitian to work on eating a low-protein diet. That will also help protect your kidneys. What about the diabetic neuropathy? So I had mentioned the numbing and tingling in your feet and hands. That's because the high sugar damages the nerves in multiple ways. It mentions that you can have sensorimotor or autonomic damage your nerves. So the difference there is when you're standing, if you're not falling over, it's because you have muscles on this side contracting at some point. And then if you tilt a little bit this way, you have muscles over here contracting. All of that nerve innervation that's happening begins to kind of decline when it's subject to this high sugar all the time. When you stand up from a sitting position, what does your body do? It contracts and it pushes all this blood up to your head because your brain has to have blood, and if it doesn't, you pass out. So sometimes you see some people when they stand up, they get dizzy, their blood pressure drops. These are things that can all begin to happen from the nerve damage that's caused from uncontrolled diabetes. So what can we do to prevent that? Very important. I'm so sorry, I've been talking all morning. The diabetes, we talked about the amputations of your toes and your feet. A big portion of that is because of the nerve damage. One, if the nerves aren't working, then you're not going to feel pain. And we have people that come in and either there was a sore on the bottom of their feet for a couple of weeks that they didn't know about because it didn't hurt. Or there was a sore and they did know about it, but because it didn't hurt, they didn't prioritize going to their doctor. And now it's infected, and now the infection has moved into the bone, and now antibiotics aren't going to work. The only thing that will work is to remove the infection through surgery. So how do you prevent this stuff from happening? Again, broken record, making sure your sugar stays controlled, making sure it stays within a good range, doing proper foot care. If you have diabetes, you have got to watch your feet. It needs to be, I brushed my teeth today and I checked out my feet. I brushed my teeth. I brushed my teeth and I checked out my feet. Okay, it is that important. And then your doctor will also do an annual foot exam. So let's talk a little bit about proper foot care. The daily inspection, not just like this. You need to be getting mirrors, holding your foot up if you can't bend over or if you can't flex your knee, making sure that there aren't any sores on the bottom of your feet. I'm so sorry. Making sure you're keeping your feet clean, okay? Doing proper nail care. People do not know what proper nail care looks like. You are not supposed to have that pretty little curve. It needs to be a straight line when you are cutting your toenails across the top. You have to be really careful because you can cut your toe if you have diabetes because one, it's numb. You can't feel that proprioception in your feet as well, and you may clip your skin. Any damage to your skin because of the slow wound healing can lead to really bad results. If you're the type to get cold at night, you got to wear socks to bed. I get that's a hard line for some people. I understand. But if your feet are getting cold at night, you need to be wearing socks to bed. Wide sole shoes. You don't want a blister. You can't risk wearing a tight shoe that's going to rub your foot the wrong way and create a sore that you could still be suffering with and dealing with 6 months later. Never, ever go barefoot. Avoid smoking, no self-operations. If you get an ingrown toenail, don't try to fix it yourself. That happens all the time. They'll say, this toenail looked infected. I just wanted to remove it myself. Don't do it. It happens all the time. And then avoid sitting in the same position for long periods of time. Could you mute my mic for just a second? I'm so sorry. Okay. I'm good. Then for the eyesight. So remember that diabetes is the leading cause of preventable blindness in the United States, 27%. So even more people will develop blindness and visual issues from your uncontrolled diabetes than renal issues from your diabetes. So how it starts, you can have blurred vision, you can have empty spots, you can begin to see these dark floaters. That is always something that you should be bringing up with your doctor if you've already been diagnosed with diabetes. Again, the best way to prevent it is going to be making sure that you're keeping your glucose controlled, monitoring your blood pressure. You have yearly eye exams, not just reading the numbers on the wall, but it's a specific thing that your doctor will look at and send you to an ophthalmologist if there's any issues there. And then again, smoking cessation. For the vasculature, we know that diabetes increases your chances of strokes and heart attacks because it affects all of these arteries. Causes heart failures, causes arrhythmia. Anytime your heart is having to work extra hard, you can develop an arrhythmia, peripheral artery disease. So how do we manage and how do we make sure that we're controlling that as well as we should? You're getting your cholesterol checked. And if you're over the age of 40, you're getting a cholesterol medication. So again, doctors, you may come to your doctor and your cholesterol, you've never had high cholesterol, but they want to put you on a cholesterol medication just because you turned 40. The reason that is because studies show that your chances of the strokes and chances of the heart attacks go up so high when you have diabetes that just starting a medication will help prevent that from happening. And if you're less than 40, it's going to be based on if you're already having some of these symptoms. Okay, but lifestyle changes. I'm not just about medications. I'm not just about insulin. Lifestyle changes are just as effective as medications. Okay, we're going to see that, where is working with a dietitian? I love this. Working with a dietitian has been shown to decrease your A1C by 2%. You can go from 8.5 to 6.5. How many has ever heard of metformin for diabetes? Metformin can bring your A1C from 8.5 to 7.5. That's it. These meds are only capable of so much. Working with a dietitian not only can keep you off of a medication, it can help you more than that medication ever could. Okay? This stuff works. If you will lose 5% of your weight, your chances of developing diabetes goes down by 58%. So if you weigh, what is 5% of 200? 10 pounds. If you weigh 200 pounds and you just lose 10 pounds, you have now decreased your chances of developing diabetes by 58%. So you're decreased your chances of having to go on dialysis, of going blind, of having strokes, of having a heart attack. 10 pounds, okay? And I know 10 pounds is a lot. I am not trying to make light of that. It takes hard work to exercise and make healthy choices. But you know what else takes hard work? Going to dialysis 3 days a week and sitting there for 4 to 6 hours, all right? And those are the choices. I tell my patients all the time, it's your choice. I just want you to realize the choice that you're making. If you choose a cheesecake every day for lunch and you choose that cheesecake knowing that I could end up on dialysis, this is a free country. You have that right. But I want you to be aware of the choices that you're actually making. For every so maybe you can't lose the full 10 pounds, or maybe that 5% is just a little, you feel like it's out of my reach. I can't do that. That's too big of a goal. For every 2.2 pounds you lose, there was a 16% reduction in the progression of your diabetes. So it's all about this progression of symptoms and progression of complications, okay? You don't just start out with great kidneys and then the next day you're on dialysis. It's a progression. You begin to see your kidney function decline, and you begin to, your vision gets a little blurrier and more blurry and more blurry until eventually, you're struggling with full blindness. So if you will just lose 2.2 pounds, then the progression slows by 16%. When it comes to exercise, recommended exercise, there's an actual number, 150 minutes a week, okay, which is 2.5 hours for the whole week. So if you want to do 30 minutes a day for 5 days a week, if you want to hit it hard and go an hour on Monday, an hour on Wednesday, well, then you only have 30 minutes of catch-up to play over the weekend. So if you will hit that 150-minute goal of exercise every week, 37% decreased chance. For the people who exercised compared to the people who did not exercise, their chances of developing diabetes was an entire 37% lower, okay? And then we've already talked about working with a dietitian. Who's ever heard of the healthy plate method? Yeah? So what I love about the healthy plate method is that you're not having to read the back of boxes. You're not counting the carbs. You're not counting the calories, which is very effective. Don't get me wrong. That's a great way to do it, but it's also a lot of work. And maybe you are overwhelmed with your job, or you're overwhelmed with your family, or you're traveling all the time, and you just don't have the capacity to do that. This makes it a whole lot easier. So your plate, a happy plate, healthy plate, half of your plate should be vegetables, okay? It's just that easy. Half of it should be vegetables. Who here doesn't like vegetables? I usually get that. Some people really dislike vegetables. But then there's a lot of people who say, oh no, I love vegetables. And I'll say, when's the last time you ate some? Well, we love them. We've got to make them available for us, okay? So a great way to do this is Walmart makes pre-mixed salads, okay? You can mix it up, put it in a bowl, pull that bowl out when it's time to eat your lunch or eat your dinner. Easy peasy. Half your plate can be a salad. Protein, 1/4 of your food, 1/4 of your plate should be protein, and 1/4 of your plate should be carbs. or grains or starch, and we're going to talk about some healthy ways to choose your carbs, choose your proteins, and even choose your vegetables, because not all vegetables are healthy, okay? So these are just some examples. Doesn't that look good? Doesn't that look yummy? That's a healthy, happy plate. So choosing our carbs. We want to try and choose carbs with fiber, okay? Because fiber makes us feel, I thought I misspelled it. Fiber fills us up. We feel more full for longer. If we're eating a carb that's going to make us feel full faster, then we will be eating less of those carbs. So your whole grain breads, cereals, lentils, brown rice over white rice, fruits rather than fruit juice. Those are all carbs that we can eat that will make us feel full for longer and will be a healthier choice in compared to our less healthy carbs, which are the refined ones, the one that's been processed a lot, your white rice, your white bread, tortillas. They have a lot of added salts and fats. You can easily Google lists of whole grain carbs versus your processed and finds all kinds of different options. And then, of course, the cookies and the cakes and the crackers and the sugary drinks. I put it up here, never say never, okay? Because if we are truly trying, if we're sacrificing something that we really love and we say that, I'm no more, not doing it, it probably ain't gonna happen. We've got to be realistic with ourselves. There is nothing wrong with a little treat every now and then, okay? So never say never if that is truly your enjoyment in life. So 30 to 50 grams of carbs per day is what is recommended. What does that actually look like? Everything listed on this page on the right is 15 grams of carbs. So 3 times a day you can pick one of these, all right? 1 slice of bread. So if you eat a sandwich, that's 2 of your 3. That means I really got to watch what I eat for dinner, or I really need to be watching what I eat for breakfast. Fruit is a carb. It is a healthier carb, yes, but it is still a carb. So if I eat a sandwich and a banana for lunch, that should truly be my entire carb limit for the day. So I put this up here because I don't think we realize necessarily all the time just how much carbs we're consuming in a day, okay? You may eat a healthy breakfast and then a salad with your sandwich, and then you say, and I ate fruit for lunch, I ate fruit for my dessert rather than that cake, so you're like, oh, I've done really good. Let me treat myself for dinner with the cookie. Just be aware, okay? Choosing your proteins. So remember, 25% of your plate needed to be proteins. Why do we like to throw proteins into the lunch? That's because it helps keep our glucose more regular, because it takes longer. Protein still will break down and have some glucose in it and have some carbohydrates involved, okay? But it breaks down at a much slower rate, and so instead of your sugar shooting up and spiking, it's a gradual, it's more stable, it's what you want. And then it also affects the overall absorption of your carbs and the rate that all of the carbs are absorbed with each meal, and it's much easier on your body, much healthier. You do want to try and pick your low-fat proteins, which we're going to go over. Some good examples over here on the right would be fish. Fish, you want to aim for at least twice per week. Your red meats, you want to limit to 2 times per week. That's because they have a higher fat content, and you got to worry about all of these things as well. If you are going to do chicken, trying to do skinless chicken, you have a lot of the unhealthy fats, which can also worsen your diabetes in the skin. And then plant-based proteins is also an option, which a good plant-based protein option would be beans and lentils and tofu and seeds and nuts. So let's say that you just really don't like fish and you just are sick of chicken, and I've already eaten my beef twice this week. You can have some seeds or nuts or beans to mix in to get some good protein in with your meal. 1 gram per kilogram of protein per day is your goal. Choosing your vegetables. We talked about it. Not all vegetables are equal. So most of them will not increase your sugar, and you can pretty much eat as much of those vegetables as you want. The exceptions are your starchy vegetables, which can be some of the good ones: potatoes, corn, yams, sweet potatoes. Those are considered carbohydrates. You really want to try and do the greens, the colorful ones. Your red, your yellow, your green, oranges. Those are the vegetables that you can probably bank on the fact of having a very low carbohydrate, if any, content in them. Best way to cook them is to boil them, bake them, or grill them. Fresh is best, you can remember that. But any of those other options are great ways to get your vegetables in. I say, don't forget about canned and frozen vegetables. Just like I love the bags of salads because they're easy, I love the bags of frozen vegetables because they're easy. Canned vegetables are still vegetables. Frozen vegetables are still vegetables. So don't feel like you have to have fresh produce every meal, half of your plate every time. Choosing your fats. Remember, we kind of talked a little bit. We talked about how your arteries are affected and your chances of heart attacks and chances of strokes, and we got to watch our cholesterol. Your fats that you eat can greatly impact your cholesterol. So the bad form come from the saturated fats. So that's the skin on the meat. That's the red meats. That's why we try to say only eat it twice per week, because that can really increase the bad cholesterol. And then your coconut oil and palm oil aren't as good as an option as like your olive oil and your avocado oil, because those are the unsaturated fats. So another portion, easy trick to remember, just like the healthy plate method. This is something that you don't have to have a scale, you don't have to be counting things. How do I eyeball it? So when it comes to your starches, if you will hold up your fist, that is the amount of starch. If you're having rice with your dinner, it shouldn't be no more than your fist, which isn't a whole lot. Same with pasta. So think about the last time you ate a plate of spaghetti. Did you have more noodles than a fistful? Because if you did, that's more than what we should be eating with our spaghetti. With meat, it's just palm of your hand, and that doesn't include your fingers, okay? It's not a huge portion, especially like in our American diets when we can go to Wright's Barbecue and you're getting a whole lot more meat than right here on the palm of your hand. And then the thickness of that steak, can't get a big old steak that's that thick and say, well, it's just the size of the palm of my hand. It really shouldn't be more than the width of your pinky. That's the recommended portion. So I'm not saying go from that 12-ounce steak down to that pinky width steak, because that's too drastic. But if you're aware that that's the goal, well then maybe instead of the 12-ounce, maybe this time I just order the 8-ounce. Every little bit helps, okay? When it comes to fat, I like vegetables, but I like them kind of in some oil, all right? Or I like butter. I love butter. No more than the tip of your thumb. That's how much of the fats you should be getting. But the good news is, in the vegetables, how much can your hands hold? You can have enough vegetables to fill you up until, hey, it's going to be a while before I'm hungry again, okay? As long as it's those pretty colorful vegetables, that's what you can get. Meal timing is important because with glucose in your bloodstream, we don't want that spike. We didn't really talk about that today. A lot of people now wear the glucose monitors, which are really, really cool. I'm not diabetic, and I've worn them before because I wanted to know, what am I eating, what am I doing that's causing my glucose to shoot up? Because we realize a lot of the damage that's being caused is being caused even worse from the spikes. So consistency is key. So especially if you're a type 1 diabetic, or if you're really trying to get your A1C controlled, you want to be as consistent as you can. And the way to do that is to eat on a schedule. You know, making sure that you're eating your meals at the same time, that you're not skipping breakfast, that you're trying to get your breakfast at a certain time, trying to get your lunch at a certain time. You're not waiting 8 hours in between meals. The longest you want to go is 6 hours in between your meals. And if you have to go longer, then you want to be grabbing a good, healthy choice snack. All right. What questions do we have? About anything diabetes related? Yes.
You talked about plant-based proteins.
Uh-huh.
And some of those also fall into the carbohydrate category, like beans and legumes.
Uh-huh. So remember, you need to first prioritize the carbohydrate limitation. And they are a carbohydrate, but they were one of your healthier carbohydrates. And so you can give yourself a little bit more leniency. Yes. Yes, sir.
I thought you were going to talk about treatments.
Treatments. So with the treatments, there are insulin options, which with insulin, you have long-acting insulin versus short-acting insulin. If you're not on any insulin, long-acting is the way to go because you take that injection once a day. It's not going to tank your blood sugar, so you're not going to have to be worried about hypoglycemia because with diabetes, if your sugar's too high, it'll eventually kill you. If your sugar is too low, it'll kill you right now. So you do not play with hypoglycemia. And so when you have a long-acting insulin, the way that it works, if your sugar's up here, it just slowly lowers it, and it keeps a basal, like just a certain amount of insulin in your body at all time. So usually when you are started on insulin, that is what you will be started on. And it's not as complicated as having to check your finger every meal and then calculate how much insulin to give yourself. You're just checking your sugar once a day, and that's in the morning before you eat. With pills, there's a lot of different options. There's metformin, which is it's a very old pill, okay? We know that it is a safe medication. There are some really cool anti-aging properties that come with metformin. They've done studies on rats that showed that the rats who were on metformin didn't develop arthritis like the rats who didn't have metformin. But it can only do so much. It can only lower your A1C by up to 1%. So if you're on metformin and your A1C is not controlled, well, then you have to add a second agent. And if it's not controlled, then you have to add another agent. It's never, let's replace it. You have to add on. There are medications called SGLT2s, like Jardiance. Have y'all heard the catchy? I've got some friends and their kids sing that Jardiance jingle all the time. Jardiance, all of that class, they're great because they help protect your heart, they help protect your kidneys, and they lower your glucose. How many has heard of the GLP-1s like Mounjaro and Ozempic, the big weight loss injections that are weekly injections? They were created for diabetes. They're not a new med. We've been using them for a long time. It's just all of a sudden now they're being marketed for weight loss, and they are very effective in weight loss. So when you are discussing treatment options with your doctor, used to it was everybody gets metformin. First line option, first line treatment, everybody. Now the American Diabetic Association says no. Look at the patient that's in front of you. Look at their total picture and then pick which option is best for you. If you come to me today and your A1C, we're just now diagnosing diabetes and your A1C is greater than 10, well then we're probably going to talk about insulin. If you come to me and your A1C, we caught it early, maybe it's just 7, but you have a cardiac history, your family has early heart attacks or strokes, well, we're going to go one option. But maybe you come to me and your A1C is just 7, but you're obese and you want to lose some weight. You need to lose some weight for your health. Well, then we're going to go this different route. Treatment looks different for every single person. It also looks different. What if you have arthritis and I can't inject pen and insulin every day? It's too hard for me. Or I'm so busy with work, I can take 1 pill a day, not twice. Like, don't try to get me to take something in the morning and at night because it ain't going to happen. Diabetic treatment is very individualized, but there are so many options. So many options that will get your sugar down, that will help protect your heart, help protect your kidneys, and prevent all of those complications that we've talked about. Is there a specific treatment that you were interested in?
Well, so I guess I'm interested in insulin resistance.
Mm-hmm.
And I'm wondering if there are natural cures, there are natural products I see on Facebook a lot of like testimonials saying,
Mhm.
you know, take berberine, take,
Cinnamon, and I know cinnamon is commonly talked about.
yeah, yeah. So what about those? I mean,
I'll tell you what's sad about that is that there's not money in cinnamon. And so pharmaceutical companies have not put all of this finances into, because it's expensive to run studies. They're not going to make money off of cinnamon, and so there's not a ton of studies out there that show how beneficial cinnamon really is. And unless I have the actual scientific data that proves something works, then I don't feel comfortable recommending it. And functional medicine is definitely gaining popularity. It's gaining ground. It's getting more popular in even the smaller towns. That's an area that's really beginning to put that research into those areas, which is what we need. You know, we need the more natural options and the more holistic approaches to keeping our diabetes controlled.
but you don't learn that in med school, do you? And all you learn is to keep pumping the medications that have been.
And we learned the nutrition, and we learned the exercise. So like I said, nutrition and exercise can work more than those medicines.
But nothing on the natural things like cinnamon or berberine or chromium or,
No.
yeah. Because there's a big push on, I'm on Facebook quite a bit, and you get these Tom Hanks saying, you know, look, I got complete control of my diabetes.
Right.
Using this compound and this compound.
And this is what I always recommend when people come and we talk about let's trying some different approaches. I am all for it. I love it. The less medications you can be on, the better. But let's not waste a year on seeing if cinnamon is going to work. Let's do everything we can to get your A1C controlled, and then let's start taking away. Because if you get on a diabetic medication, you don't have to stay on it. There, especially like as people, when they come to me and have diabetes and we start these medicines and then they say, you know what, I'm going to change my lifestyle and I'm going to lose weight and I'm going to start eating healthier and I'm going to start exercising. As their A1C lowers, then we start taking those meds off. You may have been on 2 in the beginning. Let's go down to 1. You're still controlled. You're still losing weight. Let's stop them altogether. You can do the same thing with the cinnamon or with the chromium. You can start the medications to make sure we're controlling your glucose quickly so we can get rid of that risk for stroke quickly. And then as these other things begin to work, you can start taking them away and see how you respond.
So if you're on metformin and insulin, and your A1C drops from 10 down to 5.5,
Yeah.
is A1C at 5, is that measure valid since you're being medicated to get to that level?
Yes, it's still valid because that shows how high your glucose is. You just want your A1C less than 6.5.
Yeah.
Okay? So once you start seeing someone's sugar drop into the 5s, well, you start cutting back on the dose or you start taking away meds altogether. And as long as it's not going back up to greater than 6.5, but the only way that will happen is if you have made the lifestyle changes that you're needing to make.
So I see my glucose level will bounce around.
Yeah.
Some nights it'll be 250 and some nights it'll be 137.
Mm-hmm.
So what's recommended in terms of treatment with the long-acting insulin in that case?
So
Do you up the amount of insulin if it's 250? And do you cut it back if it's 137 or 140?
nope, you're supposed to change your long-acting insulin only based on your glucose when you have been fasting for at least 8 hours. So if you check your sugar in the morning before you eat anything, that's the number that matters when it comes to your long-acting insulin. That's how you titrate that.
What if that bounces around?
Even if it goes up high during the day, it's going up Are you talking about in the morning?
No, from morning to morning.
From morning to morning, if it's bouncing around and it's staying high, then your doctor will likely increase the amount of long-acting insulin that you're
But
taking.
you increase it on the day that it's high, and then when it's low, then you go back to your 10 units or whatever?
No, it's something, you call it like a 2x2 rule, which is what I would talk about with your doctor. Long-acting insulin doesn't work quickly and not quickly, okay? So it's just a baseline amount of insulin in your body at all times. So if you eat a lot of sugar that day, it may go up, or if you don't eat a lot of sugar, it'll stay more flat. But if your sugar is greater than like 130, 2 mornings in a row, then your doctor may increase your insulin regimen. But he wouldn't say, you know how you take a short-acting insulin? Have you ever been on a sliding scale insulin?
I don't think so.
Okay, some people, what they do is they eat and then they check their sugar and they say, my sugar's 300, I need to give myself this much insulin. Or my sugar is 200, now I need to give myself this much insulin. That's a totally different type of insulin compared to long-acting, and so you don't manage your long-acting insulins that way. Yeah.
You do manage short acting.
Yes. But short-acting insulin it's a lot more work. It is 3 times a day because it only lasts for a couple hours and then it's gone. It is, you have to check your finger prick much more frequently. It's just a lot more work. If you can just be on long-acting insulin, it's a lot better for your lifestyle.
How do the GLP-1 medications work on diabetes? Like, what exactly is their mechanism?
So, one, they are messing with the hormones that are involved in the breakdown of the glucose, and then they help slow your GI tract. And remember, when you're slowing everything down, that keeps things more stable. They do cause weight loss. Weight loss in itself improves your diabetes. They have all diabetic medications except for the insulin have multiple ways that they help control your diabetes. Some of them are increasing the insulin production of your pancreas. They're helping that pancreas get louder. Some of the medications are increasing that cell and that door to open up to make it more sensitive. So they all usually work in multiple ways.
Okay, thank you.
Yes, sir.
What do
And-
you know about insulin pumps?
Insulin pumps,
Really, exactly.
That's the response we've got from a lot of people.
yeah. So are you a type 1?
No, it's a parent.
Okay. Insulin pumps are definitely useful. They have their place. They can be dangerous because they're going to pump out insulin into your body. So if you're not eating the way that you should, you're still getting that insulin. And so you can become low. And like I said, lows kill you right now.
Beat goes off all the time.
Yes. Uh-huh.
So we have to keep her in another car. No. We have to keep her somewhere where we can't hear the beat.
They can really, especially with a type 1 diabetic, because remember with type 1s, your body's not making any insulin.
They're not sure if she's 1 or 2, but that's
So she
Yeah.
has the.
CGM, uh-huh.
She has the
Pump.
thing, but you can't get those things coordinated where you can get them from the same person and know that they're gonna work together. You just have to read the readings on the pump.
Yeah.
And hope that
Is
the thing you bought
correct.
from, it's very frustrating.
Yeah.
There's nothing better to do than that.
Then an insulin pump.
Once you are using the insulin pump, is there any better way to get it
man,
all working together?
Are you working with an endocrinologist?
yes.
Okay. The endocrinologists are that's their specialty. They run that game. In my clinic, I won't mess with an insulin pump. That is
Okay,
beyond my scope.
okay.
Yep. But I do hear a lot of frustrations, especially for people who are just getting started on them, because there's a long trial at the beginning, and trying to get that coordination between the two and trying to make sure that you're adjusting to the lifestyle of having a pump.
Been on them for 2 years.
Oh.
Yeah, there's no,
It's 10.
it's 10, look at it. She's
Oh, no.
had it for a long
It is difficult getting people who actually, particularly any nurses or anywhere to even get assistance with it,
Yeah, I know.
so.
I know it's a
Okay.
struggle.
There's no advice you can give us?
Why did she do the pump instead of the injections?
I do not know.
Okay. I've seen some people who all of these things should be conversations with your doctors. And it's about your lifestyle. If she was someone who at the time she thought it would be easier because she didn't like poking her finger 3 times a day, or she didn't like doing the injections, and she wanted to try it, maybe even though that this is not perfect, maybe it's better than the alternative, which is an injection every night and then 3 injections every day. So it needs to be very individualized, and life changes. At one point in time, this insulin pump may have been the best option for me, but maybe not. Maybe my life has slowed down. Maybe I am more used to insulin and short-acting versus long-acting, and I have a little bit better understanding, and I can do injections versus a pump.
I was just curious what you might know about it.
Yeah.
But you don't use the pump at all
I don't.
in any kind of,
No.
so everything is an injection.
Mhm.
If you have to take something, it's gonna be an injection.
And so why don't you like the pump? Because it can be dangerous, because you have that contiguous insulin, and therefore it can lead you to having lows?
Yes. Now, that's one reason. Another reason is, again, that it's beyond my scope. If I have patients that want a pump, I just refer them to someone who knows enough about them, which is going to be an endocrinologist.
Okay,
Yeah.
okay. Thanks.
Sorry.
We give up.
She's gonna take care of herself.
Thank you.
Thank y'all.
Thank you for the presentation.
Yes, thank y'all for coming. Sorry I started choking halfway through.